Welcome to ACG Virtual Grand Rounds. We're thrilled to have so many of you joining us for this live presentation today. My name is Animesh Jain. I'm an assistant professor of medicine in the Division of Gastroenterology and Hepatology at the University of North Carolina, Chapel Hill. My clinical practice specializes in inflammatory bowel disease, and I also have a strong interest in education at the medical school residency and fellowship level. I will be your moderator for the Q&A period that follows the presentation today. Some notes: all attendees will remain in mute and listen-only mode. If you have any questions, please type them in the question box. We will answer as many questions as we can after the presentation and hopefully have a robust discussion. A handout with the slides and room to take notes can be downloaded from the control panel, and handouts with larger slides will be posted to the Virtual Grand Rounds page tomorrow. Following the webinar today, an email with a link to the CME and mock evaluation will be sent to all attendees. If you do plan to claim mock points, we encourage you to think about what you will change in your current practice based on what you've learned during the presentation today. These answers will be reviewed by program staff. ACG will continue to offer virtual grand rounds weekly. You can see some of the upcoming presentations on the slide here. Please visit gi.org/ACGVGR to register for future sessions. Here are the relevant financial disclosures for today's activity. And now it is my pleasure to introduce our speaker today, Dr. Sarah McGill. Dr. McGill is an associate professor of medicine at the University of North Carolina at Chapel Hill. Her recent publication with Dr. Scott Commons was the first to describe GI-isolated alpha-gal allergy in the GI literature. She is active in innovative, patient-driven research and is the co-chair for the ACG's International Grant Subcommittee. I will go ahead and hand the presentation over to you, Dr. McGill. We look forward to your presentation.
Thank you. So today I'll be talking about alpha-gal mammalian meat allergy, what you as a GI physician in particular need to know. I'll start with a quote from a patient of mine with alpha-gal who said, "It's been 3 years of desiring bacon. I like meat, but I don't like throwing up." At the end of this presentation, you should be able to describe symptoms of alpha-gal allergy and how sensitization happens, understand what activities in geography put patients at risk for developing this meat allergy, and how to manage alpha-gal allergy. I'll start with a case. This is a middle-aged woman with a history of high blood pressure, diabetes, and tobacco use who presented in 2019 with a 2 to 3 year history of nausea, diarrhea, and abdominal distension. So she was having abnormal stools. She would have days of some mucously small caliber stools, and then days without any stools. And then every 3 months she would have these attacks where her abdomen would swell and grow, quote, rock hard, followed by a lot of diarrhea and urgency to defecate, and this could last for days. She ate either pork or beef daily and routinely cooked her vegetables in lard. Extensive workup was performed, including lower and upper endoscopy, which were normal hydrogen breath tests, and a rapid gastric emptying test. She did not recall a tick bite, but was found to have an elevation of alpha-gal IgE over the detectable limits in October, and she was instructed to stop eating mammalian meat. At follow-up 10 months later, she said that her GI symptoms had resolved apart from some feeling of postprandial fullness. She had followed the mammalian meat-free diet, but had tried eating beef twice, and both had caused her to have GI distress. The second time she had actually developed urticaria, along with her abdominal distension, pain, and diarrhea. Alpha-gal allergy is a delayed food allergy to a sugar present on the cells and tissues of all non-primate mammals. The sugar in particular is galactose, alpha-1,3-galactose, and common foods that contain this are pork, beef, and lamb. The allergy appears to develop following the bite of a hard tick and has been described in the medical literature in Australia, the US, Europe, Africa, Central and South America, and Asia. This is an online map of self-reported alpha-gal cases. The symptoms of alpha-gal include GI symptoms, abdominal pain, diarrhea, nausea, along with skin symptoms, hives, urticaria, angioedema. It can, in some cases, involve multiple systems. That's how anaphylaxis is defined. And in some severe cases, cause hypotension and respiratory distress. The typical delay between eating meat and reaction is between 1 and 7 hours. So here's a schematic of the pathophysiology of this allergy. First, a tick. In the US, it's mainly the lone star tick, bites the mammalian host, let's say a white-tailed deer. The deer's blood cell have the alpha-gal sugar. When the tick next bites the human host, that causes the human to develop IgE antibodies to alpha-gal. At some point in time later, the sensitized human eats mammalian meat, let's say a fatty, juicy steak. The alpha-gal sugar is absorbed by the GI tract, bound to the fat and the glycolipid, which likely accounts for the delay in reaction. When the antigen alpha-gal binds to the IgE antibodies that are located on mast cells, the mast cells degranulate. So in the GI tract, when the antigen binds to these GI mast cells that are sensitized with IgE specific to the antigen, that's that blue cell, they degranulate, releasing their abundant supply of histamine and other effectors. Histamine, in turn, affects smooth muscle cells, causing contraction of intestinal smooth muscles, affects sensory nerve endings to cause pain, and affects mucus glands that secrete mucus. Our immune system evolved to defend us from pathogens, and in particular, IgE hypersensitivity reactions evolved to protect us from multicellular parasites. Mast cells are richly present where parasites can enter our bodies, in the GI tract, in the skin, and in the mucous membranes of the respiratory tract. Hypersensitivity reactions can be local or they can be systemic. In localized reactions, the reaction is limited to a specific target tissue, which is typically the surface of the site of allergen entry. GI isolated alpha-gal is essentially the localized hypersensitivity reaction of alpha-gal. The key diagnostic test for alpha-gal allergy is serum alpha-gal IgE, which I think must be a cheap test because no insurer has ever complained about me getting it. However, patients with elevated IgE to food allergens can be asymptomatic, so the diagnosis needs an appropriate clinical context as well. In this case, resolution of symptoms on an alpha-gal avoidant diet. And just of note, if you Google alpha-gal testing or look for it in your testing database, you may come up with testing for alpha-galactosidase A deficiency, which is a rare genetic disease and not the test you want. This is the range of the Lone Star tick, which is the tick in the US that's been implicated in sensitization to alpha-gal. So if you're joining me on a phone and this is a small image, I'll just explain that the major area is the geographic southeast and the Midwest of the United States. Very limited epidemiologic studies have shown high rates of sensitization in North Carolina, Tennessee, and Missouri, about 1 in 4 patients tested in those areas. and little to no sensitization in the San Francisco Bay Area and Boston. Activities that put people at risk for alpha-gal are activities that put them in contact with ticks. So hiking, camping, hunting. Many people may not remember tick bites as they can leave no mark. And in particular, larval and nymph ticks are really tiny. The image on the right does show localized reactions to these Lone Star tick bites. And so many of them don't associate them with ticks. They just think they're a chigger, a quote, chigger bite. So if you're new to thinking about this, you might want to know what patients may be at more risk of having this with their presentation. So I think some obvious testing triggers in my practice are if a patient reports problems after eating meat, and if they awake at night with symptoms given the delayed in the reaction. One patient I saw reported every time she ate pork barbecue at Allen & Sons, she got tremendous diarrhea when she got home, and she had alpha-gal. Another patient who had had a fecal transplant for recurrent C. diff awoke from sleep with severe abdominal pain and diarrhea after eating a hamburger. She was C. diff negative, but she did have alpha-gal. So alpha-gal is very strange among food allergies in many ways. First of all, if you're an adult GI doc, you probably don't even think about food allergies as a problem, and that's for good reason. Food allergies mostly develop in babies or very young children. Almost all food allergies happen at every exposure, whereas in alpha-gal, a patient can eat meat 4 times and be fine, and the 5th time can have an anaphylactic reaction. So it's not predictable. Lastly, most IgE reactions are immediate and occur within a few minutes of exposure. For that reason, IgE reactions are called immediate reactions. So the mainstay of managing patients with alpha-gal allergy is removing the alpha-gal from the diet. This means no mammalian meat, and if that doesn't help, no dairy as well. A lot of alpha-gal patients do tolerate dairy, but it does have alpha-gal, so it can cause problems. Patients may have problems even with gelatin in capsules, so they could consider eliminating that as well. In the case of a known exposure, they can take a long-acting antihistamine like cetirizine. And typically, our allergist will prescribe an auto-injectable epinephrine, but that is likely not necessary for the majority of patients with these GI isolated manifestations and low alpha-gal titers. And as a note, patients could anaphylax with porcine valves and other mammalian-derived medical products, so they should be counseled on that as well. Here are some clinical pearls from Scott Commons, my colleague at UNC Allergy, who has a large practice of alpha-gal patients. First, as we discussed, the response to meat is highly variable, and fattier cuts of meat or drinking meat with alcohol is more likely to induce a reaction. There actually does exist a seronegative alpha-gal, patients whose IgE are negative, yet have an allergy on a monitored challenge after eating meat. And reversely, patients with elevated titers can be asymptomatic with meat ingestion. Lastly, patients can be desensitized and be able to eat meat over time. Dr. Commons recommends following alpha-gal IgE titers, and then if these drop significantly, a self-challenge with a big bowl of ice cream is reasonable. And if that goes well, then eating a 1/4 of a pork chop is an okay next step. So I'm going to move on to what's been published on the subset of alpha-gal patients with only GI symptoms. If you're a gastroenterologist, your patients will likely not be presenting with rash or problems breathing, but instead these GI symptoms alone. I'll be presenting 2 retrospective cohort studies, both published earlier this year. The first was in gastroenterology by myself, along with Mike Croglio, a medical resident, and Scott Commons, the allergist, entitled Isolated GI Alpha-Gal Meat Allergy is a Cause for GI Distress Without Anaphylaxis. We looked at patients in 2 Central North Carolina GI clinics who had presented with GI symptoms and isolated GI complaints, and whom we subsequently found to have elevated alpha-gal IgE titers. We excluded 2 patients for confounding factors, ileal Crohn's disease and daily cannabis use. There were 16 remaining patients, and all of them had follow-up, with a median follow-up of 14 months. We recommended a mammalian meat-free diet to all the patients, and half of them also had an allergy consult. Among the patients, abdominal pain, nausea, and diarrhea were the most common presenting symptoms. 7 of the 16 patients met diagnostic criteria for irritable bowel syndrome, diarrhea predominant. 3/4 had recalled a tick bite. On the slide is a reminder of how tiny these ticks can be, with the proportions of a dime compared to a nymph tick. The median titer for the alpha-gal IgE among these patients was 0.61, and 80% of the patients strictly avoided meat, with the rest partially avoiding meat. Interestingly, a majority of these patients also stopped eating dairy as well. So here are the results of symptom improvement on follow-up. 3/4 of patients had either resolution of symptoms, no symptoms, or significant improvement, defined as only mild or mild intermittent symptoms for which they did not seek follow-up. 1/4 of them only had subjective improvement, but continued symptoms for which they still sought care. 8 of our patients had re-challenged themselves with meat in order to see if they still had a reaction. 6 of them had had repeat episodes of GI distress on challenge and gone back to the alpha-gal free diet. Only 1 of these patients had a systemic reaction, the patient that I discussed at the beginning of the talk. 2 patients had eventually returned to eating beef and pork during the follow-up period. So 2 months after our paper was published, this study, Alpha-Gal Allergy as a Cause for Intestinal Symptoms in a GI Community Practice, was published. And this is from a group in Lynchburg, Virginia. This group had been increasingly testing for alpha-gal in patients with unexplained abdominal pain, diarrhea, nausea, and vomiting as a standard practice. They looked back and they had tested 1,112 adult patients in a 4-year period, and 1/3 of those patients were alpha-gal positive. 122 of these had follow-up data. When they looked at the patients who were alpha-gal positive and alpha-gal negative, there really was no big difference in their GI symptoms, other than a slightly increased postprandial exacerbation in the alpha-gal patients. Only 3% of alpha-gal patients had remembered having a tick bite in this group, and that was more than the alpha-gal negative patients. A minority of patients, 4% of the alpha-gal patients, had hives, and 2% had experienced bronchospasm. Um, 80% of the patients in which follow-up data existed reported symptom response to a meat-free diet, and the median follow-up period was 3 months in this group. So I'm sure there are skeptics in the audience that are sitting thinking, okay, these are retrospective studies, they're prone to recall bias and inclusion bias. Patients with functional GI illness often respond to placebos, and this alpha-gal allergy may be common in the Southeast population. So let's just look at some more rigorous studies in the allergy literature that showed that patients can just have GI symptoms. I'm going to talk about 2 challenge studies. Challenge studies are the way allergists prove food allergy. They give the allergen, and they monitor the patient. In this one, the allergist took 12 people who had been diagnosed with alpha-gal allergy and 12 healthy controls. They fed them beef sausage, and they monitored them. And none of the control patients had any problems, and 10 of the 12 alpha-gal patients had reactions from 3 to 7 hours after the challenge. In this study, just 2 of the patients had GI symptoms alone, abdominal cramping and grumbling stomach. Here's a picture of one of the patients 7.5 hours after eating his sausage. He developed widespread rash. The largest alpha-gal challenge study has taken place in South Africa, where the researchers gave beef sausage to 112 kids and adults with a diagnosis of the allergy. Among those, 81 patients reacted, and all of the people who reacted suffered GI distress, including sustained abdominal cramping, nausea, vomiting, and diarrhea. Half had skin symptoms. Among the patients who reacted, 45% of them only had GI symptoms. In 21 of these patients, they were symptoms the monitors could see, like vomiting and diarrhea. And in 17 patients, they were just subjective reporting of severe abdominal cramping. So I've talked about what alpha-gal is and reports of GI isolated alpha-gal. Now I'd like to take a couple of minutes to step back and ask why. Medicine doesn't evolve in a vacuum. What are the environmental, social, cultural, and biologic changes involved? Well, first, ticks mainly, the Lone Star ticks, they mainly feed on large animals. And one of the most important hosts is the white-tailed deer. A deer can host over 1,000 ticks at a time. White-tailed deer are edge feeders, meaning that there's not much food for them deep in the forest, but they love the vegetation on the edges of fragmented habitats. And urban sprawl and low-density development have created a lot of edge, and the deer population has exploded in the US. Also, there are fewer hunters in America than in the past. Here's a pic of myself and my little brother hunting when we were little. We grew up hunting, and yet neither of us as adults hunt, and that is part of an overall trend. We also know that our gut microbes, the trillions of bacteria, billions of viruses, and plentiful fungi that reside in our GI tract play an important part in training our immune system. Things that deplete our gut microbes, like antibiotics, low-fiber diet, cesarean section, are associated with higher risk of allergic illness. Here's a slide from the Sonnenbergs at Stanford who tested fecal diversity in stool samples among Americans and then hunter-gatherers and rural agrarians in Africa. Each dot is a person's stool sample. The x-axis is their age, and the y-axis an index of microbial diversity. You'll see all the blue dots, which are the Americans' fecal microbial diversity, is at the bottom of that diversity index. Okay, I'm gonna spend the last few minutes talking about how alpha-gal was discovered, because it's a pretty interesting story. In 2008, just across the street from me at the Lineberger Cancer Center cancer doctors were really alarmed. They had just started giving the monoclonal antibody cetuximab to patients, and the first 3 patients had developed anaphylaxis, becoming hypotensive and requiring resuscitation and hospital admission. This was weird. It was already approved by the FDA, and in the clinical trials, the rate of hypersensitivity was low at 2%. Then they started talking to cancer doctors in Tennessee and Arkansas and found that it was happening there too, although doctors in New York, by contrast, thought they were crazy. In 2 published reports, patients receiving cetuximab in North Carolina, Tennessee, and Missouri had severe hypersensitivity reactions at high rates. 1 in 5 had had a severe reaction. So cetuximab had a murine component, and they found that was heavily glycosylated with alpha-gal. They found that the patients who had the anaphylactic reactions had high IgE antibodies to the alpha-gal sugar. At around the same time, doctors at UVA who were treating patients who had presented with these allergies and reactions to meat also found that IgE was high in these patients to alpha-gal, along with IgE to pork, beef, and lamb, but not to chicken or turkey. Lastly, a lot of different studies have contributed to the finding that tick bites were the cause of sensitization. Here's one study that looked at patients presenting to an allergy clinic, and patients with high levels of IgE to alpha-gal and high total IgE had much higher rates of remembering having had a tick bite or a trigger bite compared to patients with low IgE to alpha-gal. So here's a quote from Mark Twain. "I was gratified to be able to answer promptly, and I did. I said I didn't know." There's a lot we don't know. We don't know what proportion of patients only have GI symptoms. We don't know when we should test for alpha-gal. We don't know which patients will improve on an alpha-gal avoidant diet and which won't. And we don't really know when patients should improve if they're going to improve. So here are my take-home points. People can develop IgE antibodies to the alpha-gal sugar after a tick bite and then can have allergic reactions. These allergic reactions happen after eating mammalian meat and are delayed by 1 to 7 hours, and some are local to the GI tract. Current testing is with serum IgE to alpha-gal antibodies, and current management is mammalian meat and products avoidant diet. I'd like to thank you for your attention. I'd also like to thank Nick Shaheen, my division chief, Bob Sandler, CGIBD director at UNC, Scott Commons, Mike Croglio, and all my colleagues at UNC that make it such a great place to work. I am really interested in your questions, so thank you.
All right, thank you so much, Dr. McGill. That was a really interesting presentation, and I think we all learned a lot. We do have some questions from the audience, and anyone who's in the audience, I encourage you to continue posting your questions, and we'll try to get through them. I think we have some time today for discussion. So one question that came up, I think there's some clarification on which specific types of meats and foods are implicated here. I think you alluded to mammalian meats. So part one of the question was meats like poultry, which are considered white meats, generally are non-mammalian and should not lead to alpha-gal allergies. Is that correct?
Right, so this is only mammalian meat, so anything with hair or hoofs, things like pork and beef, bison, deer, Chicken is fine, so fowl is fine, they're not mammals, and fish is just fine as well.
So kind of a second part to that question was, you mentioned pork as a food that these patients should avoid. What about if it's pork that is a lighter, like a white meat in the pork? Would that be okay, or would that still have alpha-gal in it?
Yeah, so that's a really good question. All the tissue in the pork has alpha-gal, but it seems that alpha-gal, only when it's bound to lipids, can trigger this allergy. So, there is fat in probably every cut of pork, but the fattier cuts will be more likely to induce the allergy.
Okay, that makes sense. A kind of a slightly different question, but one that was very interesting was, you discussed how this is an IgA mediated response. One question that came up from the audience was, what about patients who are perhaps on immune suppressing medications from other conditions? Would they still suffer from this? Do we know if they would be at lower risk of developing alpha-gal from immune suppression?
I don't know the answer to that. I think that, the studies on this are very limited and they haven't looked at the risk in different populations. But I could say that, who seems to be more at risk for getting the allergy, the very limited studies are that patients with more atopy, that have more IgE-mediated illness like allergic rhinitis and asthma, are at somewhat more risk of getting the reaction.
I see. I think that makes sense as well. We're going to go back to diet a little bit. You presented some of the food challenge studies. So there was a question, just a curiosity question. Why is there a reason that sausage was chosen specifically for those challenge studies? Was it due to high fat content or some other reason that you're aware of?
Right, that's exactly right. So it was chosen because of the high fat content. I would also mention that challenge studies usually are typically double-blinded, for the most rigorous challenge studies, but that was deemed to not be feasible in this reaction. And also, they're usually a small amount of the allergen. If you think about, kids with peanut allergy, they can have reactions with a very small, even aerosolized amount. And yet, patients with alpha-gal tend to have to eat more to get the reaction. So that's why they chose that reasonable size of of sausage to give.
So do you think that there is a clear dose response? Is it really just dose driven, or are there other reasons that might explain the variable sort of alpha-gal response in different patients?
Well, in individual patients, again, like fattier cuts of meat are typically more of a problem. Also, for some reason, having alcohol with the meat potentiates allergies, and that's been found in other food allergies as well. And also, for some reason, exercising with or close to the meat ingestion also can kind of make you more likely to have a reaction.
That's really interesting. That's very interesting. I suspect that there's a lot more to be done to understand that. So the question that was on my mind is a practical question. In one of in your summary slide, you mentioned when should we test for alpha-gal? So I think that's probably the question on a lot of our minds. So Dr. File brought this up as well. Who should we be testing? In the lack of guidance or guidelines in your clinical practice, who would you test for alpha-gal allergy?
Well, I think myself, like the practice in Lynchburg, because my general GI practice is in a rural area with high known rates of sensitization to alpha-gal. At some point, I just started regularly testing patients with unexplained abdominal pain, diarrhea, nausea, vomiting, those kinds of things. I started out by testing just patients who, said that they had had a tick bite, or patients that just woke up at night with GI distress. My very first patient I diagnosed was soon after I moved here from the Bay Area, and she had had two really bad bouts waking her up at night after eating a hamburger. So I had heard about alpha-gal from a colleague of mine who has anaphylaxis from it. And she was high, and I told her not to eat meat. So in summary, it's a good question. We don't know. It depends on where you're practicing, I think. If you have alpha-gal in your region, if you're in that yellow region, and also, some history can be helpful, like tick bites and, where the patient has traveled. But often there's not enough time to get all those details to help us decide who we should and shouldn't test.
So it sounds like in your practice, Dr. McGill, based partially on the geographic region that you're in, you have a relatively low threshold to test now for alpha-gal in patients with unexplained sort of abdominal pain. Is that fair?
Sure. Yes, that's about fair. I would say, if someone has alert symptoms, red flag symptoms like weight loss, rectal bleeding, and things like that, those are patients I wouldn't test because I think it could possibly delay getting to the true diagnosis. And, we don't think that alpha-gal causes those symptoms.
Sure. And there was also an interesting question that I think we're probably all wondering, and maybe an area for future study. Has anyone looked at alpha-gal in a patient in a population of patients with irritable bowel syndrome? Is there some overlap, or could it be that some patients who we have diagnosed with irritable bowel may in fact have alpha-gal?
Yeah, that's a good question. We haven't done that yet, but I think it's interesting to think about. Um, it's hard to know, in a group of patients, we need to understand who's asymptomatic, who has GI symptoms, who has severe symptoms. The severe ones usually present themselves, and we just don't know that.
Okay. There are a few questions about the testing specifically. Just practical points. Which test do you order, and what lab does the testing? Is it easily available? Can you give us some details about that?
So I know that LabCorp does do alpha-gal testing. It's part of their meat allergy panel. They look for IgE to beef, IgE to pork, and then IgE to alpha-gal. And usually patients with alpha-gal will actually have elevated titers of IgE to all of those. So yeah, I think it is widely available. It's also available kind of at my local lab as just an alpha-gal, a standalone test for the IgE.
And you said at LabCorp that's called a meat allergy panel. Is that right? I've never heard of that. That's interesting.
I believe so, yeah.
Okay. And then somebody brought up a test called ImmunoCap, which I believe is a Quest diagnostics test. Have you heard of that? Are you familiar with that one? I know that we're getting pretty deep in the weeds here with testing.
I know ImmunoCap was actually used when they were trying to figure out alpha-gal and what was causing it. So yeah, it must be an IgE test to different antigens.
Yeah, from looking it up, it looks like that may work, but I can't find black and white confirmation of that. There's some questions about sort of the pathogenesis and ticks here. So is there any sort of connection or overlap between alpha-gal and Lyme disease, given the common tick vector?
Yeah, that's a good question. So first of all, I showed the map of the world and all the places where alpha-gal has been. So it has been associated with other ticks other than the Lone Star tick. It's been associated with Ixodes ricinus and Haemophilus longicornis in Japan. And so I don't think the Lyme disease tick is a vector, but that is Ixodes scapularis, and it does have alpha-gal in its salivary glands, even in an unfed state. So it possibly does, but I think that the experts on this think it's mainly the Lone Star tick that's causing the sensitization in the US.
I see. So it's mainly Lone Star. And if I read your map correctly, somebody asked about South Carolina. That seemed to be in the high risk areas.
Oh,
correct?
yeah, absolutely. South Carolina probably does have high rates of sensitization, although I don't know of any studies that looked at a South Carolina population.
That's right. It's not too far from where you are. Probably you have patients who drive up and see you occasionally.
Right, right. Worldwide, so yeah, they haven't tested many populations, but they did test school children in Kenya, and actually that was the highest rates of sensitization. That was 50%. They tested kids in rural Ecuador. That was very high, 1 in 3 tested, and then about 1 in 5 in people in North Carolina, Tennessee, 0% of people in Boston, 0% of people in northern Sweden, and 1% of people tested in Northern California.
See, interesting. That it's interesting how striking that geographic variability is.
Mm-hmm.
So broadening out from thinking outside of the U.S., one of our participants commented that she has hardly seen this in India, which I think there could be multiple plausible reasons for that. Perhaps it's ticks, perhaps it's diet. Do you have any speculation on other countries?
Yeah, that's interesting. I haven't read a single case report or case series from India. So yeah, it may not be a problem there. I don't know whether, I think there are ticks in India, so maybe it's, you know, the allergy link or the microbial link or something. I don't know.
Yeah, perhaps it's related to the tick vector. There are also higher rates of vegetarian people in India, so that may be one factor as well, but you'd still expect to see some cases, so that's interesting.
Mm-hmm.
Somebody asked a really provocative question. Do you think that alpha-gal allergy may lead in any cases to perhaps triggering other diseases like EOE?
Oh, that's actually been looked at, I think. So Evan Dellin and Scott Commons looked at rates of alpha-gal sensitization in controls who were just coming for endoscopy and in people with EOE, and they were both very similar. So they didn't think that it could trigger EOE because the controls also had sensitization at similar rates.
I see. Okay, so at least that's one thing our patients don't have to worry about is getting EOE from the tick bites, at least.
Right.
So I was wondering, when somebody gets alpha-gal, would their IgE titers go down over time, and would it be possible to hence reintroduce, mammalian meat products for those patients?
Yes, they can go down over time. And actually, one of the things that the allergists do counseling these patients is tick prevention. So kind of stuffing your pants and your boots when you're going for a hike, and using tick protective clothing, using light colored pants to identify ticks when they are crawling up you, because patients whose IgE levels can decline over time then can get resensitized after tick bites. And in a study that smacks of kind of self-investigation, there was one reported case of a person who had an identifiably normal IgE level to alpha-gal and then got 50 bites of the Lone Star tick, and the IgE to alpha-gal shot up, 12 times. So the other question was, at some point, can these patients re-challenge themselves? I think the answer is yes. I mean, I think it was interesting that a lot of my patients had re-challenged themselves during follow-up, and many of them, hadn't felt well after that and had resumed the kind of mammalian meat-free diet, but 2 had gone back eventually to eating meat. So it can happen.
So a follow-up question to that was, is there a specific either time frame or a specific IgE titer level that you would be looking for to help guide when to reintroduce meat products?
Yeah, I haven't guided patients on these, but Scott Commons has, and he recommends that the alpha-gal titers should fall to a more normal level and then kind of re-challenge starting with a big bowl of ice cream, because that might be, less of a problem than actually eating meat.
Mm-hmm. It's kind of a milder challenge before going straight to meat.
Yeah, interesting that he has challenged the ice cream people, because some of the first patients he saw were complaining of problems after, particularly after ice cream, and he's done challenge tests with ice cream in 3 alpha-gal patients, and sure enough, they had the delayed reaction.
I see, but you're not necessarily following their titers in order to help guide when to re-challenge them in practice.
I have not. I mean, I honestly, have not, a lot of these patients I didn't see before they re-challenged themselves. They decided to re-challenge on their own. So I just hadn't been following their titers.
That sounds like an interesting area for further study, potentially, of what can we do with these patients going forward.
Right, absolutely.
So, people are very interested in the tick. So you mentioned that there are some other ticks besides the Lone Star tick. You also mentioned that some patients don't recall a history of having tick bites, but do we think that it is always mediated by a tick vector, or do we think there's any other mechanism by which a patient could develop alpha-gal allergy?
So right now, it's just thought that sensitization happens after these tick bites, for multiple reasons. Kind of the people with tick bites have more alpha-gal. In experimental studies, patients who get a lot of tick bites at once with the vector get the allergies and get sensitized. So the allergists had looked at other means of sensitization, maybe aerosolized means, but that did not pan out. Interestingly, humans do produce other IGs to alpha-gal. We produce, just normally without any sensitization, we produce IgG, IgM, IgA, and IgD to alpha-gal. And this is probably stimulated by our gut flora, because in alpha-gal deficient mice in germ-free environments, they don't make these antibodies.
I see. One question about the symptoms specifically, just clinically, what we can expect for our patients, how long do the symptoms typically last once a patient has eaten that hamburger and they have symptoms? Are we expecting just a few hours, or what kind of time frame are we expecting?
Yeah, I think we need a prospective study on this, because I don't know. I think and then even in the challenge study, they didn't say exactly when these kind of GI problems, like how long they lasted. But yeah, I don't know that. Good question.
So it's not exactly chronic symptoms. They do sort of get better, and then kind of the abdominal pain would flare back up with their next exposure. It does seem to be triggered by the food exposure.
Yeah, I can say that anecdotally, at least one of my patients who had very, very classic IBS symptoms, like I thought she had IBS. She was fine, but then she started having these diarrheal, urgent stools. She had to plan her day around the bathroom, that kind of thing. And she took alpha-gal out of her diet mostly. She actually had problems going to Subway, and she thought that was from kind of cross-reactivity. They prepare the turkey on the same place that they prepare the pork or the beef. And she, after taking alpha-gal out of her diet, didn't get complete symptom resolution until about 2 months after the diet. So I don't know if that was just her GI tract having to equilibrate, or she was having some alpha-gal in her diet during those 2 months that her symptoms took to resolve. But interestingly, she had problems, had a couple problems on follow-up, after her symptoms had resolved, just inhaling bacon, like the bacon that was frying in a house that she was working construction on. She had like a day of mucousy loose stools after being exposed like that. Another patient that I know of actually had an anaphylactic reaction. He had a history of anaphylaxis. He was hunting, dressing the deer, and didn't ingest the deer, but just the exposure on dressing the deer caused an anaphylactic reaction.
Wow.
So you don't necessarily have to eat to be exposed to the allergen.
Wow. Are you aware of any sort of family tendency or predisposition for alpha-gal allergy?
No, I don't. I don't know of any kind of genetic predisposition. Again, in the cetuximab studies, among the patients who had the hypersensitivity reactions, they tend to be more atopic, like eczema, asthma, allergic rhinitis, compared to the patients who just did fine with the infusion.
And one, I think, final question, from me. So, I think myself and many of us are still very new to this and don't know as much about this condition. Are we alone in GI, or do other specialties that are much more aware of this, like allergy or medicine, or is this something that everyone is learning about in the medical community?
It's really been, as far as medical literature, it's really been only the oncologists who were interested in it because of cetuximab, and the allergists who have published on this mainly. I mean, these 2 GI studies were published this year, but apart from that, there hasn't been a lot in like the general medicine literature, in the ER literature, even though these patients are definitely presenting to ERs with these attacks, because several of my patients did, and I'm sure the Lynchburg group saw that too. So yeah, I think it's something that really was described in 2008, and there's not an awareness about it.
Right, and I don't think we have any solid understanding of the actual prevalence of this condition, aside from the small retrospective studies you cited. Is that correct?
Right, that's true. The studies on alpha-gal have more been mechanistic, kind of lab translational studies. There are really not many epidemiologic studies on it.
Okay. I think we covered all of the questions. I think we had an excellent discussion here today. So Dr. McGill, do you have any final closing comments before we wrap up for the audience?
I'm so happy that you joined me. Thank you so much. And please email me or reach out if you have any questions. I'm happy to discuss this with you.
All right, so thank you so much to everyone who's able to join us for the presentation today. We hope that you found this interesting. This was a wonderful presentation. We hope you have a few key takeaways that you can take to your practice. And for anyone who has additional questions that we didn't get to cover, we will be continuing the conversation on the ACOG GI Circle. So thank you so much, everyone, for joining us. And thank you again, Dr. McGill, for the wonderful presentation.